We are continuing our journey that we've been on for the past few weeks, talking about how a healthy relationship with food and your body can go wrong. So today's lecture is about eating disorders, what they are, how they develop, and I call it the perfect storm because as we've discussed, these don't happen overnight. There's no switch that gets turned on or off that designates who has or does not have an eating disorder. So throughout our journey together, we've talked about how we have intuitive eating and flexible eating habits when we're young. We have a healthy relationship with food, but over time, sometimes this can change and we can have food rules. We can end up developing unhealthy relationships with food and our bodies. We can become preoccupied with things like dieting or exercise as an attempt to alter our shape and size, which can lead potentially to disordered eating, unhealthy dieting, distress about one's shape and size, subclinical exercise, issues with obsessive exercise. As we talked about last week, about 25% of college students nationally in the United States exhibit some kind of subclinical eating disorder, and maybe slightly higher at Boise State, depending on the data we're using. So I want to talk today about those clinically diagnosable eating disorders. And I know we've talked about this before, but I want to say this again because I think it bears repeating. No one is immune. So yes, there are genetic predispositions to eating disorders, especially anorexia nervosa and bulimia nervosa. Less is known about binge eating disorder in terms of genetic predisposition, as that is a relatively new diagnosis, only in the past decade or so. So studies are still out. But we used to think when I started studying eating disorders 20-something years ago that this was a thing that happened in women who were white and upper middle class to upper class. That's not true. Anyone potentially can have an eating disorder, regardless of gender, sexual orientation, age, personality types. Anyone can fall into that trap, right? Somewhere along that path that we've been talking about. So how does this develop? How do we go from that disordered eating and subclinical eating disorders we talked about last week to a fully diagnosable clinical eating disorder? So just to kind of give you an overview, the best guesstimate right now is that 30 million Americans at some point will suffer from an eating disorder. 2/3 of those diagnoses right now are binge eating disorder. So although it's a relatively new diagnosis, it is the most commonly diagnosed of all of the eating disorders. 1/3 of those diagnoses are in men. There's an increased risk of comorbidity, and so it's very common, for example, for someone with anorexia nervosa to also be diagnosed with an anxiety disorder. Someone from bulimia nervosa to also be diagnosed with a substance abuse disorder or an impulsivity, impulse disinhibition type of disorder. So there's a lot of comorbidity around these eating disorders. And if we talked about just before, this is not an island. They don't just develop overnight, and there's usually multiple causes that go into this. So the fact that there's a lot of comorbidity with diagnoses is not surprising. The sad fact is that eating disorders are deadly. The second highest diagnosis in terms of mental health issues that lead to death is anorexia nervosa, recently surpassed in the past couple of years by opioid use disorder. Eating disorders are on the rise in all populations since the start of the COVID-19 pandemic. They're especially on the rise in minoritized populations. I know that our guest speaker, Kaylee Featherstone, who's going to come in and talk to us this week, will talk quite a bit about what's on the rise and why. She's also going to talk quite a bit about this trans-diagnostic approach. So the idea that in the past few years, although insurance companies are still pressing for a diagnosis of anorexia nervosa, bulimia nervosa, binge eating disorder, a lot of times it's not that simple. And so she will talk about the trans-diagnostic approach when she comes to class. So because we are at Boise State, I wanted to touch a little bit on the prevalence of eating disorders at Boise State University. So over the past couple of years since the start of the COVID-19 pandemic, we've been collecting data in my lab. And one of the questions that we ask is, have you ever been treated for an eating disorder? Right now, the records are about 5 to 6% of students will check, yes, I have been treated for an eating disorder. That's relatively similar to national collegiate data that comes to Boise State every few years and collects data on our campus. Although the last data that was collected by the NCHA was pre-COVID, so we're waiting to see when they come back to campus if that rate increases or if that stays the same. But again, I want to emphasize that for you to be counted, you have to have been diagnosed and treated, right? So most people who have an eating disorder will actually never get diagnosed. So that only counts those, again, who are diagnosed and treated. And I go back to the data that we talked about last week, where 20 to 40% of Boise State students are currently meeting the cutoff for a high risk for clinically diagnosable eating disorder. So we suspect that that 5 to 6% is probably a little bit on the low side, and it's probably quite a bit higher than that. What most people don't understand is that an eating disorder isn't a choice, right? And so I talked about this before. I have a good friend who wrote a book called Just Tell Her to Stop. She's a therapist who was tired of dealing with parents who came in to her office and said, just tell them to stop, just tell them to knock it off, just eat normally, have a good relationship with their body. It's not that easy, right? So I love this quote because it really emphasizes that it's not a choice. It's not a switch that gets flipped. It's something that happens over time, as we've been talking about. It's a disease that, like an addiction, is a trap, right? And so just like any other kind of addiction, it is in some ways a coping mechanism gone awry. And so we'll talk a little bit more about that in a minute. So how does this develop? And so as we talked about, there are many, many reasons that lead someone on this trajectory from a healthy relationship with food in their body to a relationship that is so unhealthy that they meet the diagnostic criteria for an eating disorder. So yes, genetics play a role. Anorexia or nervosa, depending on the study, is, we think, 50 to 80% heritable. So it's very common with family members who have one family member diagnosed with anorexia nervosa to have multiple family members who are diagnosed with anorexia nervosa because of that genetic component. We think that there's also some heritability for bulimia nervosa and also perhaps binge eating disorder. Anorexia nervosa is the most studied, and so we know the most about it when it comes to genetics. But the environment is also playing a role here, right? So environmental triggers that may lead to someone making choices over time that lead to the development of an eating disorder. And as I said, eating disorders usually start out as a coping mechanism. So those with diagnoses of eating disorders typically don't come from healthy, happy childhoods where everyone is adjusted and normal and nothing goes wrong. Right? So it's usually a development over time where someone turns to the relationship with food in their body in an attempt to control or cope or deal with what is happening in their lives, and then make choices that over time will lead to a diagnosable disorder. So I want to emphasize again, it's not just that something goes awry, that you have a genetic predisposition and bam, you have it. It doesn't work that way. So yes, genetics are involved, but clearly there are environmental factors and other triggers that are happening. So what we know about eating disorders is that, again, during that trajectory of moving from a healthy relationship with food in your body to an unhealthy relationship with food in your body, things start to happen in your brain that over time exacerbate that unhealthy relationship and can then lead from that healthy relationship to an unhealthy relationship to a full-blown diagnosis. And so 3 things that are pretty common in those diagnosed with eating disorders are that the changes in their brains over time have led to a visual processing deficiency. And so when they look in the mirror or when they look at bodies, they actually don't see them as someone who doesn't have an eating disorder sees them. And so think about the TV shows with the chalk outlines of crime scenes, right? And so if the chalk outline is supposed to represent the accurate placement of the person's body, and in this case, the accurate shape and size, someone with an eating disorder would see a distortion in that. And so they would not see the chalk outline as someone who doesn't have an eating disorder sees it. They would probably see that chalk outline as being larger than it actually is. So a deficiency in visual processing. So they no longer have the ability in their brains to see bodies accurately, their own and other people. There are also often working memory deficits. Some of this may come from malnutrition. So along this road, when we're making unhealthy choices about food, if we start doing a lot of caloric restriction, if we're doing a lot of binging and purging, and our bodies and brains are not getting the nutrition they need, that can lead to working memory deficits over time. That again just exacerbates this problem. And again, sometimes we also have from frontal lobe deficiencies, meaning that someone with an eating disorder, and then over that trajectory of time, will begin to make decisions in a way that doesn't make sense to someone who doesn't have an eating disorder. So poor ability to plan, poor ability to make a decision that makes sense in a healthy way for most people. And again, part of that may be a result of malnutrition, and part of that may be the result of brain changes that have actually happened as this journey has progressed from a healthy relationship with food in the body to the unhealthy relationship with food in the body. So I want to go over the 3 most common diagnoses that we see and hear about when it comes to eating disorders. Again, Kaylee will talk about the trans diagnosis approach because it may not be that simple, but insurance companies often still want a diagnosis that is recognizable. So I want to go over these signs and symptoms. So anorexia nervosa is probably a term that's familiar to most of you. What does that look like? So there are some emotional and behavioral symptoms, and then there are also some physical symptoms that go with a diagnosis. So someone who suffers from anorexia nervosa usually has dramatic weight loss. So they may be underweight, severely underweight. They may not be, but typically there is a lot of weight loss that happens before the diagnosis is made. They tend to be preoccupied with weight, food, calories, dieting, the way their body looks. They're afraid, really, really afraid of weight gain and being fat. And so again, anorexia nervosa often has an anxiety component that goes with it. And so there's often a comorbid diagnosis of an anxiety disorder with anorexia nervosa. Because of this fear, they refuse to eat certain foods or maybe entire food groups. They tend to develop food rituals around what they can and cannot eat, around when they can eat it, how they can eat it, who they can eat it with. Typically, they eat by themselves. They tend to deny that they are hungry. So they turn off that cue, that they just ignore their body's signs and symptoms that I'm hungry. They consistently make excuses to avoid meal times or be in situations involving food, because they're very anxious around eating with other people or around how other people will perceive them when they eat and how they eat. Because of the malnutrition that tends to go with anorexia nervosa, there's a number of physical symptoms that also tend to develop. Dizziness from low blood sugar, feeling cold all the time, not enough body fat, or just thyroid issues with not being able to support adequate hormone production because of the malnutrition issue, tend to have trouble sleeping. It's very difficult to sleep if you're very hungry. Dry skin because they're not getting enough nutrition again to keep their skin nice and moist. They tend to faint because of the dizziness. If you're female, menstrual irregularities, so missed periods or amenorrhea, so stop ovulating and menstruating altogether. Impaired immune function, as you can imagine, if you're not getting enough nutrients, it's going to be very hard for your bodies to operate appropriately at an immune response level. And then gastrointestinal complaints. So they typically have deprived themselves of food for so long that when they do eat, their stomach hurts, or they have other gastrointestinal issues that go along with that. Bulimia nervosa is another common diagnosis within the eating disorder realm. Again, we have a series of emotional and behavioral signs and symptoms as well as physical symptoms. So the first thing that you probably notice with someone with bulimia nervosa is evidence of binge eating. So a disappearance of large amounts of food, hoarding of food, purging behaviors that go along with the compensation, the compensatory mechanism of trying to quote unquote get rid of the food. So I had a student a few years ago who discovered during our class that her son had bulimia nervosa. And the reason she found out is that she went into his room and she just heard a really weird noise. And she looked and she knew it was coming from the floor. She couldn't figure out what it was. And she finally figured out he had stuffed the floor vent in his room with empty candy bar wrappers. So he had hoarded some food and eaten it all, binge eat, and then was trying to hide the evidence of his binge eating from his mother. So he stuffed them in the vent. He'd stuffed them under the bed. She also found hoarded cereal boxes under the bed so that things that were ready for him the next time he wanted to binge. So a lot of food in a very short period of time. And then again, the evidence of purging to try to get rid of that food. So it may be frequent trips to the bathroom, it may be laxatives, diuretics, excessive exercise, fasting, some way to compensate for calories eaten for that binge eaten. And as you can imagine, they tend to have extreme mood swings, right? So there's a lot of guilt around the binges, and there's a lot of dissatisfaction with appearance. And so they can have these pretty dramatic mood swings, especially if they're also trying to purge by restricting and they're not eating enough on some days. They get hangry, just like the rest of us. And so you may seem happy-go-lucky one day and then depressed one day or angry one day. So mood swings are pretty common with this. Physically, you may see fluctuations in weight, or you may not, right? So there's no, again, hard, fast rule. It's not like they gain 10 pounds, they lose 10 pounds. It's not the way it works. So depending on where they are in their binge purge cycle, you may see weight go up and then weight go down, or you may see nothing. Body weight is often, for those diagnosed with bulimia nervosa, in the normal range or be slightly overweight. So they don't have the excessive thinness or excessive underweight that we often associate with anorexia nervosa. Because of the purging, if they tend to purge by throwing up, one of the first people who actually may notice something is wrong is the dentist. Because the stomach acid, when you throw up, if you do that enough times, will actually start to erode the enamel on your teeth and cause cavities, sensitivity, decay. You also may see if someone is purging by vomiting, cuts and calluses across the joints of fingers from sticking it down the throat. And then also they tend to display difficulty in concentrating because they're always thinking about food, that next binge or the next purge. So binge eating disorder. The simple way to explain it is that it's bulimia without the purging. That's an oversimplification. They are two different distinct disorders. So again, you're going to see some of the same emotional and behavioral symptoms and physical symptoms, but they are considered two distinct disorders because there typically is not a purging that goes along with binge eating disorder. So you're still going to see evidence of binge eating, of hoarding, of being uncomfortable eating around others because of fear of judgment, withdrawing from friends and activities, especially around mealtime, frequent dieting to get rid of any weight gained on the binges, concern about body weight and shape, disgust, depression, guilt after overeating. And again, some of those same physical symptoms. There may or may not be noticeable fluctuations in weight. There may be gastrointestinal complaints like stomach cramps from overeating and other kind of non-specific gastrointestinal complaints like constipation, acid reflux, etc., and then difficulties concentrating. So I like this image of the binge eating cycle here in the lower right-hand corner. So there's always an emotional trigger, right? A need isn't being met, and that emotional trigger triggers the binge, but then you have that in kind of the emotional backlash of feeling disgusted and depressed and angry and tired and guilty. And so then there's usually a promise to be good, quote unquote, but then you end up with the unmet need, because again, for most, eating disorders are a coping mechanism, and so that binge eating and purging, in the case of bulimia nervosa, or just binge eating in the case of binge eating disorder, is a coping mechanism. And so when you get triggered, this is the go-to method often for coping. So again, it may not be that simple. There may be symptoms that cross diagnoses. You may have, there's an anorexia subtype that's actually the binge purge subtype. So sometimes you'll have someone who says, I have anorexia and bulimia. What they actually mean is that they have anorexia nervosa with the binge purge subtype. And so the compensatory mechanism for eating anything, not even a binge, but eating anything, may be some kind of purging. And so again, Kaylee's going to talk more about that transdiagnostic approach when she comes to class. So I want to talk for a moment about recovery. Kaylee will talk about this as well. Eating disorders have the second highest mortality rate of any mental illness. Again, during the pandemic, the past couple of years, that was surpassed by the opioid use disorder. And again, one of the biggest issues with eating disorders is the lack of individuals getting diagnosed and treated. So the guesstimate is that only 1 in 10 will seek and receive treatment who actually need it. And treatment is most successful when intervention is early. So it's really important that we are honest with our families and friends and treatment providers to make sure that we get the help that we need. When it comes to recovery, there's anecdotally in the therapy world, it's called the 60-20-20 rule of thumb. With treatment, about 60% of those diagnosed with an eating disorder will make a full recovery and be eating disorder free at some point, actually do make a full recovery. Without treatment, about 20% of those suffering from anorexia nervosa will prematurely die from other eating disorder related health complications. Similar rate for bulimia nervosa. That's often caused by heart issues, usually by the electrolyte imbalance caused by that purging. Suicide also is a common mechanism where those with suffering with eating disorders who are left untreated may actually commit suicide because they just can't take it anymore. And then about 20% will continue to suffer kind of off and on and be in and out of treatment. Treatment is very, very pricey. Ranges somewhere from $500 if you're outpatient to $2,000 per day if you are in treatment in a residential treatment center. In Idaho, there is no residential treatment center at this point. We have different levels of care. We have a lot of outpatient providers, and we do have what's called partial hospitalization and intensive outpatient through an organization called Center for Change here in Boise. And Kaylee, I'm sure, will talk more about those as well. So how do you know? How do you know when you should be worried about yourself or about a loved one? There are a lot of signs and symptoms. I just want to go over some of the ones that are most common in terms of warning signs, early warning signs. Constant adherence to very strict diets, increasingly so. So regardless of weight, it could be that the person in your eyes doesn't need to lose weight and they just keep dieting. They can't help themselves. Habitual trips to the bathroom immediately after eating to purge, secretly binging on large amounts of food. Again, in my student who found her son's hoarding under his bed and in his vent. Increasing consumption of laxatives, diuretics, diet pills, excessive exercise, even when sick or injured, often for several hours a day. Using prescription stimulant medications or illicit drugs to suppress appetite. Withdrawal from friends and family, especially around meal times or when you probe and ask questions about illness or about eating disorders or body image. Avoidance of meals, preoccupation with weight, body size, shape, or specific aspects of one's appearance. So it's always first thing in their mind, and so they often talk about it. obsessing over calorie intake, calories burned, even as you're losing a significant amount of weight. There are a number of resources at Boise State if you or a loved one who has access to those resources is in need. So we do have counseling services that will see you. There's a body positive group counseling available. You can go through the Dean of Students and file a care report on yourself or a loved one, and they will reach out and ask if there's anything that they can do to assist them. We have dietitian services. We have Body Acceptance Week that happens every year. The peer health educators are always facilitating body image and body acceptance types of events. And just the most important thing we can actually do is just to stay educated and join the conversation. Eating disorders are often suffered in silence, and the more that we talk about it, the more that we normalize the fact that it's okay to ask for help, and that asking for help is a good thing.